Hello all. So welcome to Gynae Wizards channel. So I think it's been a long while since I posted some video. So today I'm back with a new snapshot and it is my snapshot number 7. So let's start with a brief case scenario. So yesterday my postgraduate called me and told me that there was a patient in the postnatal ward, para 1 living one, who's just delivered 3-4 hours back and she has difficulty to pass urine. So she's not voided since her delivery. So she had a vaginal delivery which was uneventful and there was no prolongation of first stage or second stage of labor. And she had an episiotomy, that is a right mediolateral episiotomy. There were no other tears or PPH or there was no any perineal edema as such. So then I asked her, so how do we manage this case? So today we are going to discuss about something called as postpartum voiding dysfunction or postpartum urinary retention. So many a times we don't speak about this problem, but voiding dysfunctions and urinary retention are usually unnoticed and they are not asked when the patient is immediately delivered or either by a vaginal delivery or a cesarean. So the underlying prevalence of postpartum voiding dysfunction is around 14 to 24%. So this is a significant problem. So we all must ensure as obstetricians, we have to go and ask the woman or the mother immediately after delivery. It could either be a vaginal delivery or a cesarean delivery. So she should have been passed urine, so at least within the first 4 hours after delivery, that if it's a vaginal delivery or after the catheter is removed in cases of cesarean section. So if she's not passed within 4 hours, we can add an extra 2 hours. So within 6 hours, we have to ensure that she has passed a good amount of urine. So this is a very important aspect that should be remembered as a part of postnatal care. So we have to also remember that postpartum urinary retention is sometimes unnoticed and it cannot be predicted in the usual practice. But there are certain risk factors associated with the postpartum urinary retention, also called as PUR. So today in this snapshot, we are going to discuss the pathogenesis and the risk factors which are associated with postpartum urinary retention, and also we will go through the management aspect, and it is a simple algorithm which must be practiced and it is very important to prevent the ongoing bladder dysfunction. So now firstly we will start with the pathogenesis which is associated with PUR. So what are the important risk factors which are associated with postpartum urinary retention? So firstly, the risk factors, like usually if she's a primiparous woman, there are higher chances of association of this dysfunction, and sometimes if there is a epidural analgesia as a part of vaginal delivery or a cesarean section or any other regional anesthesia as such. So whenever this epidural or regional anesthesia has been given to the woman, usually this disrupts the afferent pathways from the bladder to the pontine micturition center. So that is why this reflex arc is disrupted, and which in turn might lead to postpartum urinary retention. And sometimes the bladder might be over distended, and also the bladder might become edematous because of prolonged labor or such, and this also will not be able to send the afferent pathways or the afferent signals to the pontine micturition center. So that's why the micturition arc is disturbed, and that is why there might be urinary retention. And also, as I mentioned, if there is prolonged first stage or second stage of labor. So whenever there is a prolonged first stage or second stage of labor, there might be disruption of the micturition arc or micturition reflex, either neurologically or mechanically. So how neurologically? So whenever there is prolonged first stage or there is prolonged second stage, what happens? The fetal presenting part or the fetal head will go and press on the pelvic nerves or also on the pudendal nerves. So whenever there is prolonged pressure because of the fetal head, or whenever there is prolonged straining in the second stage of labor, this might have an adequate stretch on the pelvic nerves and also on the direct damage to the pudendal nerve. So this also disrupts the afferent pathways to the micturition center, and this disrupts the normal functioning and the uh, urinary reflex, that is the micturition reflex, and this might also lead to the postpartum urinary retention. And also when it is associated with instrumental delivery, so it's the same. There is a instrumental delivery, especially the forceps delivery, which is low forceps delivery. There might be undue pressure or undue straining over the pelvic nerves, or the pudendal nerve might be directly damaged, which will also cause postpartum urinary retention. And how does it cause? Mechanical uh, damage. So whenever the prolonged second stage or prolonged first stage of labor, or if there is an instrumental delivery, there might be perineal tears, or sometimes there might be increased edema in the vulvovaginal region or increased edema in the perineal region as well. And sometimes there might be a sequelae of vulval hematoma or some undue pressure over the vaginal walls as well. So all this, what will it cause? It will have intense pain, and there will be direct pressure over the urethra also. So that time the urethra will become tonically contracted, which also results the bladder to be distended, and this also will again ultimately lead to postpartum urinary retention. And also, as the effect of progesterone in the late part of the pregnancy, so progesterone is a hormone of pregnancy, so this progesterone remains elevated in the early puerperium period. So in early puerperium, if the progesterone levels are high, there is a relaxant effect over the bladder. So the bladder remains hypotonic and it will not contract immediately. So this will also result in over distension of the bladder, which might ultimately lead to postpartum urinary retention. So when we find all these risk factors which are associated with our delivery, or whenever there is a prolonged second stage and she is taken up for a cesarean delivery as well, that time also she has increased chances of development of postpartum urinary retention. So we have to keep in mind all these risk factors for the assessment. And immediately after the delivery, if it is a vaginal delivery, we have to ensure that the woman has passed urine. And even after we remove the catheter, in a case of cesarean section, we have to go back to the woman and ask whether she's passed urine or not. And if she's passed, we have to ask whether she's passed significant amount of urine or not. We diagnose this postpartum urinary retention. So this postpartum urinary retention, it can be divided into types. One is overt PUR and covert PUR. So what is overt PUR? Whenever she has immediate voiding dysfunction, that is if she's not micturated after delivery. So whether it can be a vaginal delivery, if she's not immediately passed urine, or after removal of a catheter in a cesarean section, if she is not passed urine, that we call it as postpartum urinary retention. That's overt postpartum urinary retention. It is more than 6 hours. So more than 6 hours of vaginal delivery or more than 6 hours after removal of indwelling catheter in cases of cesarean section. But what is covert PUR? That means whenever she has voided, but she is not voided a good amount of urine, and there is significant amount of post-void residual urine. So if there is increased residual urine, that if it is more than 150 ml, either measured sonographically or measured via catheterization. So if she's passed urine but she still has that she's not passed completely, or she still has that the bladder is full and she's not emptied completely, all if her stream is not good, Then we have to measure the post-void residual urine, and if it is more than 150 ml, then we call it as covert postpartum urinary retention. So this management is very simple. So we just have to follow this algorithm. So this is a single slide snapshot for today's discussion, and this is from a TOG article, that is the RCOG TOG article, which is a very famous article for postpartum urinary retention management. So we have to just follow this algorithm. So before this, some of the important advices which we have to give to the postpartum mother is also important. So if she expresses the voiding difficulty, or if she's already voided and feels that she is not voided completely, we have to ask her these VESI questions. So this VESI is very important. So this is whenever we identify the woman with risk of postpartum urinary retention, as I mentioned before. So if she's underwent an instrumental delivery, or if there was any prolongation of second stage, or if if she's a primiparous woman, and if she feels that she's not voided a good amount of urine, we have to ask her these VESI questions. So what does VESI stand for? So you have to ask her, did you pass a good volume of urine? So V stands for a good volume of urine, and E stands for, did she feel empty at the end of voiding? And S stands for, does she still have the sensation to pass urine? And the fourth one, again, S stands for, is the stream normal or not? And the last I stands for, is there any incontinence on cough or stress, or any urge or incontinence as well? So these basic questions are very important to identify the woman with risk of postpartum urinary retention. So once we have made the diagnosis, then we have to address the problem, and we have to give her some of the conservative management advices. So what are that? You have to help the mother to use the washroom. So you have to ask her to stand, get up, ambulate and use the washroom. And once she uses the washroom, ask her to put some cold water on her hand and in the perineal region to increase the sensation of voiding. And third, we have to ask her to take a warm bath, so that it might increase the it might cause a sensation to void. And if there is any perineal trauma or edema in the vulvovaginal region, we can ask her to apply some ice packs or have a sitz bath. So after all these also, if she still complains that she's not able to void urine, or if she's voided urine and it is not complete, then we have to follow this algorithm. So this is a very important algorithm which we follow in postpartum urinary retention. So I will be going through this algorithm for a better understanding. So firstly, we have to encourage the woman to void within the first 4 hours of catheter removal or after a vaginal delivery, and again further 2 hours we can give, and total of 6 hours, but not more than 6 hours we can wait. And if she is already void, we have to ask the VESI questionnaire. And VESI, if it suggests retention, then we have to just put an in and out catheter to see the residual urine assessment. So if residual urine is less than 250 ml, again you can give a trial for voiding within the next 6 hours. So again, within the next 6 hours, we have to see if she is voiding proper amount of urine or not. And if she is not voided, again we have to put in and out catheter to see the residual urine assessment. If the residual urine is between 2 to 700 ml, it is better to catheterize for 1 day. So we catheterize for 1 day, and again we try after removal of the catheter. We ask her for spontaneous voiding or not. And if it is more than 700 ml, that means it's a very significant amount, and uh, we cannot just neglect it. And it is always better to send the patient home with an indwelling catheter for 2 weeks. And after 2 weeks, you have to ask her to come back, and then again you have to give a challenge of removal of the catheter, and then you can see whether she voids a proper amount or not. So what happens in these 2 weeks? So the bladder edema comes down and the pain will be relieved, all the perineal trauma will be healing, and all the vaginal mucosa will be healed, and all the swelling and the edematous tissues will reduce, and also the progesterone effect will decrease, and the bladder will also become tonic, and it will resume its normal function. So that is why after 2 weeks again we can clamp the catheter and see if the woman gets the urgency to pass urine, then we can remove the catheter and we can ask her to void. So, and if she is not having any vesi suggesting retention, so if all these vesi is negative, then we have to ask her to void within the next 6 hours after the catheter is removed. And again, after this, yeah. So if the second void at 6 hours post catheter removal, again we have to do an in and out catheter residual assessment. So again we put a catheter and see if there is amount of residual urine left. And here again there is change in the amount of urine, which is important. So if it is less than 150 ml, then she is voided completely. If it's between 150 to 700 ml, again we have to catheterize her for 24 hours and just see. And if it's more than 700 ml, we have to send her home with an indwelling catheter for a period of 2 weeks. So by then the underlying bladder dysfunction will settle and the bladder function will resume and she can void properly. So this is when she's already voided. What happens when she's not voided? So she's not unable to void immediately after her delivery or after the catheter has been removed. At these instances, so we have to again do a in and out catheter residual assessment. And amount of urine she is voided is less than 150 ml, then we have to see that the urine has already decreased, that the urine output is decreased. So we have to think of other causes of decreased urine output. So is she a case of preeclampsia, or is she going into an ongoing AKI because of any other dysfunction? So all this we have to assess for the decreased urine output post delivery. But if the urine, the residual urine is between 150 to 250 ml, again we have to wait for her second void within 6 hours. If it is between 250 to 700, it is the same. We have to catheterize her for 24 hours and then again we have to trial without catheter. And last, if it is more than 700, as I already mentioned, we have to send her home for 2 weeks and we have to ask her to come back with catheter, and we have to clamp the catheter and see if she resumes the sensation to pass urine, and then we can remove the catheter. And once she's voided, again we have to do a post void residual urine assessment. So this is a very simple algorithm. So if we remember this, it is very important to identify the risk factors associated with the postpartum urinary retention, and also the management is equally important. So what did we learn in today's video? Voiding dysfunction and urinary retention are a very common complaints in the postpartum period. So it is very important for us to identify the risk factors and also know the pathogenesis which is associated with PUR. And the take home message is we have to differentiate between overt PUR, that if she is not voided immediately after delivery or after catheter removal within the next 6 hours, or covert PUR where she is voided but the residual urine is more than 150 ml, which is measured ultrasonographically or via catheterization. So once we have identified and made a diagnosis, firstly we have to encourage the mother to pass urine. We have to see her input, maintain her input output chart. We have to take her and help her to use the washroom, and we have to ask her to use an ice pack if there is any underlying perineal trauma or if there is any vaginal edema, and you have to ask her to take a warm bath and use a sitz bath. And with all these conservative approaches, if she's still not voided, or if she still has the sensation to pass urine, or if she feels that the bladder is not empty after passing urine, we have to assess by asking her the VESI questionnaire. So what is VESI? V for good amount of good volume of urine is she passed. Does she feel empty after the passing of urine? Is she having any sensation to pass urine even after she is voided? And is the stream of urine which is normal or not, or whether it is a thin stream urine, or whether it is associated with any type of incontinence? So once we assess the VESI questionnaire, then we will easily follow the algorithm. So this algorithm was given by King's College Urogynecology Department, and they easily tell that we have to assess the post-void residual urine. So if it is less than 250 or 250 to 700 or more than 700, if she is voided, and if she is not voided, if she is voided for the second time, and again we have to assess, and if it is less than 150, 150 to 700 or more than 700, or if she is not voided, again if it is less than 250, we have to ask her to void for the second time. If it is between 250 to 700, we have to catheterize for a period of 1 day and then again try after removal of catheter. And lastly, if it is more than 700 ml, we have to definitely send her home with an indwelling catheter and ask her to come back after 2 weeks, and again we have to give the challenge of removal of catheter and ask her whether she can pass urine freely or not. So hope this video has helped you to understand the pathogenesis which is associated with postpartum urinary retention and also the management as well. So take care guys, happy learning. Thank you.